Good afternoon. I'm Dr. Lindberg. The first topic we're going to be talking about in the traumatic brain injury guidelines series that we've created for the Triumph program is going to be on management of seizures in patients with traumatic brain injury. It's one of the shorter topics that we have, but it is still pretty important. So to begin with, just a little definition. For epilepsy. In general, epileptic seizures are clinical manifestations that are thought to be the result of abnormal and excessive discharge of neurons in the brain. The clinical manifestations can consist of sudden and transitory abnormal phenomenon, can include alterations of consciousness, alterations in motor behavior, sensory perceptions, autonomic features, or even psychic or psychiatric events that can be perceived by the patient or an observer. These can be transient or short-lived, and they can be recurrent as well. And so a traumatic brain injury is a common cause of epilepsy in the U.S. population. And it's the leading cause of epilepsy in young adults. And this is primarily because with traumatic brain injury, you do have diffuse injury to the cerebral cortex with multiple injury foci within the brain, multiple epileptic foci in these patients. So they do have the predilection of developing seizure activity.
Hey guys, whoever just joined us, we're super happy to have you, but we hear a mic. So if you don't mind just to check and make sure you're muted, because we hear some kind of background noise. Thanks.
All right, so post-traumatic seizures in traumatic brain injury patients, this refers to a single or recurrent seizure episode in anybody who's had a traumatic brain injury, and this includes mild brain injuries, moderate brain injuries, and severe brain injury. So this definition applies to everybody in the entire spectrum of traumatic brain injury. Post-traumatic seizures can be classified, and we'll go over those. There's 3 different classifications. There's those with immediate onset post-traumatic seizures. This occurs within the first 24 hours of injury. And again, like I said, it can be the mild to severe injuries, but it's within the first 24 hours. You can have early onset seizures, and these are the seizures that occur after 24 hours within that first week after injury. And this is usually the time frame where most folks are treated prophylactically, but Dr. McGuire will discuss that in just a little bit. And then there's the late post-traumatic seizures, and this is actually the most common. These occur with greater than a week after injury, and so these are the ones that are diagnosed once patients are generally discharged either to the rehabilitation setting or back home and into the community. And so the frequency of post-traumatic seizures has been estimated to be about 5 to 7% in the U.S. population. The more severe your brain injury, the higher the risk of developing seizures, with severe brain trauma being up to 11% in the U.S. population. And then if you do have a penetrating head injury, especially with gunshot wound injury, the frequency of seizure activity increases pretty dramatically up into 35 to 50%. And this is because you do have a more focal area of brain trauma. And so when does this occur? Usually post-traumatic seizures, the risk of it is highest within that first year after head trauma. About 60 to 70% of patients, if they are going to have a post-traumatic seizure, will have their seizure within that first year, and then 80% will have their seizures within the first 2 years. So the first 24 months are the highest risk period for post-traumatic seizure development. Now, this is a lifelong risk. development, and so patients with traumatic injury are at lifelong risk of development of post-traumatic seizures. And so in these patients, you also do have to rule out other causes, metabolic abnormalities, alcohol withdrawal, other manifestations of brain injury, post-traumatic brain injury issues like hydrocephalus, rebleeds as causes, but they do have a lifelong risk of post-traumatic seizure development. And so risk factors for a post-traumatic seizure, it's a long list, so this is not all inclusive, but this is usually the biggest risk factors are the severity of the initial head trauma. So the more severe the head trauma, the more likely you are to develop seizure activity. Penetrating head injuries, again, because there is a local foci of injury, and a cranial bleeds for the same reason as penetrating head injury, and because they usually signify worse head trauma. So epidural and subdural hematomas do increase your risk of post-traumatic seizure. The older you are, the more likely you are to, the higher risk it is for you to develop post-traumatic seizures. Any premorbid history of alcohol use also increases your risk of post-traumatic seizure activity. And then if there's a family history of development of seizure activity, that also increases your risk for seizures long-term. And so now I'm going to turn it over to one of our third-year physical medicine residents, Dr. Aaron McGuire. He is actually the author of our seizure guideline, and he's going to talk about assessment and then management, diagnosis, management, and treatment of seizure activity in patients with traumatic brain injury.
Good morning. So in regards to assessment, these patients, when we're assessing them for seizures, they're going to present with some of the classical symptoms that we all think of when we hear the word seizure. It can be highly variable in the population. As Dr. Lindberg mentioned, you can have a wide area of damage to the cerebral cortex, and as such, you can have any mixture of symptoms. You can have convulsions, blank staring spells. Again, depending on the type of seizure, you could have, for example, a simple partial seizure, and you may still have the patient remain conscious during the seizure event. Whereas a more generalized tonic-clonic seizure, they won't remain conscious, they won't have memory of what happened. Your patients may describe visual hallucinations or disturbances, auras, things of that nature. They may also have auditory disturbances. They may say they're hearing things that those around them are not aware of. You can have changes in mood or affect. You can have paresthesias, dysesthesias, electrical type sensations, or numbness. So the presentation can be variable depending on the injury. Additionally, to add another layer of difficulty to this, the TBI itself can mask some of the baseline activity of the patient. It can be altered, and therefore you may not notice some of these symptoms the same way that you would in a patient that was otherwise not having problems. So this raises the level of awareness that needs to be applied with a patient that has a brain injury. You need to pay attention to very subtle signs and symptoms, any change in baseline status in that patient. Additionally, if you haven't observed a direct change, but all of a sudden you start to notice that the patient has a new deficit, a new focal motor deficit, sensory deficit, or maybe their communication has declined in status, you may be seeing this patient who is actually in a post-ictal state. And so that should raise your clinical suspicion for maybe an unwitnessed post-traumatic seizure. The diagnosis, as I mentioned, it begins with observation. Frequently, you'll have family members that may say they're sitting in the room and the patient had kind of a weird episode where they stopped responding to them for a few seconds or something of that nature. So you need to take these reports from the family member very seriously. Additionally, you may have a report from nursing staff or physical therapy, somebody that's been working with the patient maybe on a more regular interval than the physician does. They may say that they've observed a new deficit arise or something like that. So these are things that you need to pay close attention to when you see the reports. Once you have a clinical suspicion that there may be seizure activity going on, definitively to be sure that you have a seizure, you have to make this diagnosis with an EEG. Some limitations with EEG. Typically, these studies are short, half an hour, 45 minutes. You may not actually capture the seizure episode itself. With that in mind, if you have a patient, you have a strong clinical suspicion of seizures, and they have a negative EEG, that one isolated event may not have captured the seizure itself. So one negative EEG does not rule out the presence of seizures. To further bolster your case, say you have a negative EEG, but you're still fairly suspicious of the seizure, you can order video electroencephalogram. This allows you a much longer period of observation. This will be an admission to an epilepsy monitoring unit. And typically these patients will be admitted for 1 to 3 days. There'll be video recorded while the EEG is going on continuously for that time span. So you get a much larger window of observation. And you can also see if the patient is maybe having a psychogenic event that is not actually epileptiform, but that helps you differentiate that. And these can be tricky, especially with the TBI population, because you're not getting your baseline activity may be altered. A further measure that can be taken to try and diagnose whether seizure activity has actually occurred. Several types of seizures will exhibit an increased level of prolactin in the postictal period. The thing about this is it happens, generally speaking, within the first hour after the seizure has occurred. So you have a small window of time with which you can draw the lab. Also, because prolactin is a variable hormonal level, you need to make sure that you have got a reference, a baseline to compare it to see if it is actually elevated in that patient or not. So you need to draw that lab same time of day and within a few days after the event at a time when nothing is going on as far as you can tell. So you have a comparison to make before you can declare it abnormal. So once you've diagnosed that you have post-traumatic seizures present, or actually if you suspect seizure is occurring, some things you can do immediately if the patient, say, is having a seizure in your clinic. Management, it's just the first priority is going to be protecting the patient themselves. There's a lot of drama that is associated with seizure activity. People in the community will be very alarmed if they see somebody having a seizure. So the biggest priority immediately with a seizure is to protect the patient themselves, and during the postictal state, during which they may be disoriented, confused, agitated, combative. These are all times that you need to pay close attention, be aware of the situation, and do the best thing that you can for your patient. Some of those measurements include things like positioning the patient in such a way that they cannot harm themselves, they can't fall off of a table, out of a chair, they're not near traffic. All these types of things are things you can do. They're very common sense, but again, people tend to panic with seizure activity. If the patient has lost consciousness, they're on the ground, it can be helpful to position them on one side. This can help keep their airway open if they're unable to protect it. Another thing that any bystander can do is record the time of onset and the duration of the seizure activity itself. This can be important for medical management. Some important do nots, and again, this is kind of a classic thing. People in the community will think that this is a good idea, but it is not a good idea to try and hold down the patient's tongue or anything of that nature. Again, this kind of lore persists, but it's important that we understand that's not something we need to try and do. Additionally, along the same lines, don't try and give the patient any kind of medication or anything of that nature during the actual seizure event. Remain with the patient until the seizure is completely ended. This could be 10 seconds, this could be 5 minutes, or longer. It just depends on the severity of the seizure. And of course, if there's any suspicion of compromised airway, contact EMS services immediately to protect the patient. With that in mind, status epilepticus is an absolute emergency, and EMS should be called immediately. The definition of that is a continuous generalized convulsive seizure that lasts greater than 5 minutes, or 2 or more seizures between which the patient does not return to baseline consciousness. Frequently, patients that have seizures, they may have several seizures throughout the course of the day. But if they recover consciousness between the events and the events are spaced out, that's not as concerning as if they're having recurrent events or they're just having one long constant event. So if you recognize that this is going on, this is an absolute medical emergency and you should contact EMS immediately. Aside from the acute situation, when we have a patient we recognize, we've diagnosed, we've definitely concluded that they're having seizure activity, it's very appropriate to refer to neurology for further workup and management and maybe get their opinion on the appropriate anti-epileptic drug. Additionally, if you're counseling your patients, perhaps they've tried several anti-epileptic drugs and they've not had results that have been satisfying. Kind of one of the more final measures for a patient who's resistant to drug therapy, they may need evaluation for surgical resection of the seizure foci. Another common question is what is the role of the doctor or the primary care provider in regards to the patient's driving after a seizure? The state of Arkansas does not actually require that the physician or the practitioner report the epilepsy to the State Office of Driver Services. The patient themselves is obligated to do so, but the physician is not by law required to do so. Once that is done, the Office of Driver Services may impose restrictions on their license to ensure that they're a safe driver. Once that's been done also, the patient must demonstrate that they're seizure-free for about a year, and they must also pass medical evaluation by a state physician. All of this will be reviewed, and then the Office of Driver Services will meet and determine whether or not they can achieve reinstatement of their driving privileges. In regards to prophylactic prevention of post-traumatic seizures following brain injury, different anti-epileptic drugs have been evaluated to varying degrees in regards to their efficacy. The newer classes of drugs, such as Keppra, have not been as rigorously tested as some of the old standbys as far as anti-epileptics. Currently, and this is an important distinction to make. Currently, prophylactic treatment of post-traumatic seizure is not routinely recommended beyond 1 week following head injury. So we typically see our patients, and we will begin to withdraw prophylactic anti-epileptic treatment after that first week, unless they have some sort of indication, like Dr. Lidberg mentioned earlier, penetrating head injuries, things like this that may make us a little more leery. But those are handled on a case-by-case basis. But generally speaking, prophylaxis should only last approximately a week following head injury. Some of these classic drugs that we'll cover, phenytoin is the most rigorously tested anti-epileptic drug for post-traumatic seizure. Evidence supports its use for prophylactic treatment, again, for only early post-traumatic seizures. Evidence does not support continuing prophylaxis beyond that first 7-day period. Some things to keep in mind with phenytoin, however, as we all know, it requires monitoring of serum drug levels to make sure we're within the target therapeutic range. It has significant side effects and also significant drug interactions. So it can be a difficult drug to work with. Similarly, carbamazepine also demonstrates improvement for early PTS prophylaxis. Again, early, that first 7 days, not necessarily beyond that period. Also with carbamazepine, it does require serum monitoring for the drug level and also has a large interaction profile. Keppra, again, a newer generation anti-epileptic drug, has several advantages. It doesn't require serum level monitoring, it doesn't require loading dose, and it interacts with fewer other medications. However, studies have not yet confirmed its efficacy in comparison to phenytoin and carbamazepine for prophylaxis for post-traumatic seizures. Now, if we have a patient that's in the situation that they have confirmed seizure activity and they continue to have events, then these patients, it's generally accepted, should be treated with an anti-epileptic drug, absolutely. And then once you've had a patient that has made recovery, we've been seizure-free for quite some time, and we're starting to wonder, can we withdraw this medication? Also, it's generally considered safe to start attempting a trial of withdrawal from 2 years after your last seizure event. So if you have that 2-year window, then it's safe to start trying to withdraw this drug. Particularly in reference to TBI patients, it's very important to weigh the impact of the anti-epileptic medications on cognitive performance and the safety profile against seizure risk. Currently, it's debatable regarding whether the anti-epileptic medications will cause delay in cognitive recovery following brain injury, and whether if this effect is present, whether it's short-term or long-term. And it's for this reason that we provided the recommendation to only do prophylactic treatment for the first 7 days, because we don't want to impact that cognitive recovery if we're not gaining anything in regards to the safety profile with seizure prevention.